Okay, hello everyone. So today will be about arrhythmia. So again, the class is a bit long, although the slides are not that many. So I'll still chop it out into two sections. So this part will talk about the basics of arrhythmia, and the next one will be about the medications used for arrhythmia. Okay, arrhythmia, I have to declare something which is, I always think that it's a very difficult topic to talk about. Just because it's a very specialized disease. Because arrhythmia is a big umbrella of everything underneath it. So and a lot of it requires cardiologists specialized in arrhythmia to actually, who's mainly taking care of such patients. There's a few main ones like atrial fibrillation, but there's a lot which is a lot of subtypes as well. So and to be frank, the drugs which can be used for the treatment of arrhythmia is not that good. A lot of them are not the best, so there's only certain conditions whereby some of the drugs will be more useful. So that's why it's a very tricky topic to talk about. So yeah, so I'll just say it based on what we can and what we need to know. I would say the others, we again have to rely on the cardiologist to take charge of the topic actually. Okay, so for this, what is arrhythmia? So basically, if you look at the diagram in a way, it refers to abnormality at the site of origin. It can be from the start or from the impulse. It can be the rate, which is wrong. The regularity, rate or regularity is the same thing, or is something wrong at the conduction. So in the flow is something wrong. So due to something which can go wrong at the starting of it or during the conduction pathway. So the resulting, we can get abnormal heartbeat kind of rhythm. This is what we call arrhythmia. Or it can be too slow, or it can be too fast, or the rhythm is wrong in general. So too fast, too slow, or wrong rhythm. So as mentioned earlier, it can be if I'm just using a tempo just to cheer things up. So if the tempo is boom cha cha, if that's the correct one. If your tempo is boom cha boom cha boom cha, so it's wrong. Or it's boom cha boom, so that's wrong. Or you got a boom boom cha and boom cha boom, that's all wrong. So so the definition is actually pretty wide. So arrhythmia is dangerous, right? So going to the next slide. So before we know what's abnormal, we need to know what's normal, isn't it? So normal, this is what is it. So you can see this is the general action potentially at the muscles, and the conducting muscles over here, right? So you need to know that again, the whole flow, the contraction has to be very well coordinated. So the atrial has to contract first, relax. Relax first, then the blood goes in, contract, the blood flow goes into ventricle. So ventricle then contracts, then the blood flow can go out, right? So it has to be a very coordinated action. So atrial and ventral cannot contract at the same time, for example, or they cannot relax at the same time. So then the blood flow cannot be pumped out. So how does the contraction happen? So the contraction occurs in response to the electrical impulse, right? So the electrical impulse has to arrive at the right timing as well. So as we already know, the electrical impulse starts from the SA node and then it goes all the way down, right? And it has to be one direction. So because it has to be contract or relax once, and it has to be at the correct direction flow of the impulse so that the whole contraction and relaxation can occur at the timing that you want it to be. Right, so the ECG trace over here is the PQR. So this is the normal one, and this is the membrane potential for the muscle. So there's you see the membrane potential starts in, so it starts to contract, then it slowly flows, comes down for the plateau, and so you can details you can read through over here, right? So then it goes down through repolarization, and it slowly goes up again for the next one, for the next impulse to come in and respond towards it, right? So this is how it works. So the whole implication, as mentioned just now, it has to be the timing and synchronization is very, very important. So here we're just going to show you a little bit of the common ECG abnormalities. You don't have to remember the trends because there's just too many of it. Right, so we've got remember the normal one just now, the PQRST. So in contrast, so there's all this. So the dangerous one is this one. So the ventricular tachycardia, so you can see, so basically the more different is it from the normal one, the more dangerous it is. So atrial fibrillation, as you can see, this is the more common one as well. So which is also the one which medication can play a better role compared to the other ones. So there's also so this for this ventricular fibrillation, so you can see there's no resemblance of the pattern of the PQRST thingy already, so it's all wrong altogether. So in this case you need to reset it. So this is when you actually see in the movies when when the person collapse and people use a defibrillator and they say 1 2 3 clear. So this is when we try to correct this type of ECG, because when it's too messy altogether literally, so you just have to reset it. So this is when the clear defibrillator comes in. So therefore to make sure the heart can continue to function properly. So there's a little bit of the physiology that we revised just now, and we go through the types and so on and so forth. Okay, so again, when to choose which drug to use when is always the most important part. Okay, so symptoms. So most of the time arrhythmia is actually asymptomatic, because in a way it's a mild condition of arrhythmia, meaning the ECG of the person is still not that much different from the normal one. So meaning the whole relaxation and contraction of the whole heart is still okay. So under most circumstances, so because it's still okay, so it's still coordinated, but it's not the most coordinated form in terms of the contractility of the heart. So we can still function because the heart can still pump, although the efficiency of it is not as good as it should be, but it still can work. So most of the time it's asymptomatic unless you really do some special exercise, for example. So for certain people it can be symptomatic, so dizzy, palpitation, fatigue and things like that. So there's a lot of causes, there's just too many of it. So it can be intrinsic, so it comes with that kind of spare part, i.e. for your heart, so but it can still function. So and there's no point to treat it, because as mentioned there's a lot of drugs, but a lot of it they are not the most pleasant ones. So sometimes it's better not to treat it if it is not troublesome or it's not dangerous to the person. So it can be due to genetic stuff, it can be electrolytes, because as you remember hypokalemia and things like that, it can affect the heart a little bit. The more common or the one that we can try to prevent or treat is the hypoxia or the ischemia one. So it relates to the ischemic heart disease and things like that. So and also acidosis, alkalosis. So it can be hormonal hormonal cause. Again, if it's some cause that you can treat it, obviously you try to treat the cause as usual, and also drugs. So drugs in this way is also very funny and interesting, because a lot of drugs that can treat arrhythmia can also cause arrhythmia. So yes, this is how complicated and weird the whole topic is about. So there's a lot of risk factors. So again, we try to treat the main risk factors, because these are the ones that can mainly contribute to different forms of arrhythmia. Right. So the main one again is very heart related as well, like coronary heart disease and so on. Right. So yes, as mentioned, drug that treat can cause as well. So it's a loop. So you can see the drug that can cause, you can see digoxin. You're like, why on earth is digoxin here? So beta blocker withdrawals, again, you cannot just stop beta blockers abruptly, because there's because there's over upregulation of beta receptors. So you just stop the drug altogether very quickly. So there's no inhibition on it. So there's more augmentation of the beta receptor signals, so that can also cause arrhythmia. So you see theophylline, and the thing that all the drugs here, which the names might not be familiar, but later you see them in the next session in a way. These are the drugs which can be used to treat arrhythmia actually. So yes, they can also cause arrhythmia. So why can it happen? How does it happen? So it can be, this is a very brief overall coverage. Okay, so the first thing is it can be something wrong at the start. So the start, it can be the impulse formation. So meaning it can, the automaticity of the SA node is something wrong. So it can be too slow. Right. So remember again, the heart muscles or the SA node, remember it's not just one cells. It's a group of cells actually. Right. So again, we try to make sure the whole system is designed whereby if some cells is failed, so the other cells will try to take over and try to keep up with the work again, because we want to make sure person survives, because if anything is wrong with the signal of the heart, the person can just be dead. So if the rate is too slow, something is wrong. There's actually a lot of sleeping pacemaker cells can take over the job. So because we want to make sure the heart continues to beat. So in a way, it's somebody which is kepo, or somebody, if you can say, it's trying to help to be too helpful, but because of that, there's a lot of escape beats. So there's all extra beats. So then it can cause ectopic beat, right? So, or sometimes it can be caused to direct death of the cell due to myocardial infarct. So there's a heart attack. There's some cells which are dead because they don't get enough oxygen supply. So therefore, it can be something wrong. So the signal is wrong because of that. Because the cells, obviously, when the cardiac myocytes, the cardiac cells or the SA cells, electricity cells, when they are dead, obviously they cannot send a signal, right? So yes, as mentioned over here, so when there's disruption of the cell membranes or something is wrong, they cannot run properly. So the non-pacemaker cells, again, people try to help to make sure at least the heart is still pumping, so they'll actually release its own signal. So therefore, the heart can still continue to beat in a very slow way. So that meaning they have two sets of signal. Right, so it can be loss of junction, gap junction connectivity, so the others will try to take over as well. So ectopic beat, so the extra one, so there's a lot of causes. It can be hypoxia, myocardium, or extra sympathetic stimulation. So basically something is wrong with the heart, so it cannot respond to it properly anymore, right? Right, so there's another one which is called early after depolarization. So this is the normal graph. It's supposed to come down totally, but it doesn't, so it actually goes on and on for the next signal. So this is the one which is most differ from the original signal. So this is the one which is most dangerous. So in a way, those drugs which can actually prolong the QT interval, the PQRC, the QT interval, is more prone to cause all this. Right, so therefore it's pretty dangerous, because remember, the sodium channels, which is supposed to recover and rest, they manage to respond to the next signal in a very quick manner. So therefore it's very dangerous. So it can cause this sorry, I haven't googled the actual pronunciation yet. Daily points, I'm not sure. So that's why if this happens, so this is the most dangerous form, as mentioned just now, that you need a defibrillator to correct it. So this is sustained early after depolarization. So therefore you can see that the drugs that can be used to treat can also it can be dangerous to people as well. Right, so it can be also re-entry. So this is the one that I mentioned just now. The direction, the flow of the impulse should be one way, because if there's any U-turn and so on and so forth, so the signal will go back again. So if there's cardiac myocytes which already rested, they can respond to the next flow of signal in a too early manner. So that's why there's an extra contraction. So this is something called re-entry. So you can see this is a triangle flow. So it needs two particular criteria for re-entry to occur. So you can see the the action potential comes down. So but there's this patch of cells which are literally in a way like dead. So therefore the signal has to split up into left and right in this sense. So that it goes through. It has to basically just go around the dead patch of cells, right? So but when it comes here, you can see that the direction or the speed of the signal coming should be same. So therefore, it can both go down the same way, and it can spread to the downstream of the myocytes later on. But then what happens is that when the signal comes here for certain conditions whereby the cells over here are dead in a way, so they are damaged, so they can actually flow up again. Right, so which is unusual, because remember, in arrhythmia we talk about all the unusual stuff, so it doesn't follow the normal rules and regulation. So the signal can actually turn up, right? So so the block here, so the signal here, it cannot go down this way. Somehow there's a block, right? And somehow this signal that comes up over here is really slow. So it can goes up and it's really slow, but then it can come down again. So the cells over here can respond to the second wave of signal, right? So therefore it comes in a re-entry, so you can actually get double signal, so there's a double contraction. So you need these two criteria. So the signal here is blocked down here, but it can go upwards, and the flow here is so slow enough that the contraction, the cells here have rested enough that they can respond to the second signal. So this is re-entry. Okay, so it can also be other reasons whereby it can be a conduction block. So there's scarring, remember there's MI, there's myocardial infarction, things like that. So the cells are dead. So there's certain parts which are non-responsive. So the flow is just blocked at that side. It cannot go down further. So then they try to beat slowly on their own, so it forms bradycardia. So, and for some people, they actually have this accessory tract pathway. It's only for some individual. So basically what happens is that when you look at it, there's actually another extra route that the signal can go through. So it doesn't have to go through the normal way. There's an extra route, i.e. like another shortcut that the signal can go through. So it can bypass the overall route. So therefore, and may cause a re-entries, therefore causing tachyarrhythmia. Okay, so because there's two signals that it has to respond to. Okay, that's all for this one. Thank you. See you the next round. Okay.